Hi, this is Alia and welcome to my channel. Today we're going to discuss about proprioceptive neuromuscular facilitation or PNF. Now starting with the history of PNF. So it was started by Dr. Herman Kabat in 1940s. He developed the term proprioceptive facilitation. Now where did the word neuromuscular come from? So it was Dorothy Voss that added the word neuromuscular in 1954. Margaret North and Dr. Kabat both continued and expanded the concept. Now we know the topic as proprioceptive neuromuscular facilitation. Now what is the definition of PNF? So it is the stimulation of proprioceptors for increasing the demand made on the neuromuscular mechanism to obtain and facilitates its response. Now this would be little typical. So in simple words we can say that PNF एक stretching technique है that is utilized to improve the muscular elasticity, and it has been shown to have a positive effect on both active and passive range of motions. The basic procedure includes these 7 points. First one being the manual contact. So in this the grip should be lumbrical and the pressure over the skin should be as facilitator or stimulator, and the contact must be purposeful, directional, and comfortable. The next point is commands and communication. So it is for sensory cues and is given by touching, telling, or by demonstrating visually. It includes the determinants of commands, and the first one is tone of voice. It depends on the type of patient that you have, like short and sharp tone to stress for maximum voluntary effort, moderate tone when the patient is giving best efforts, and soft tone when security is needed for the patient, and or if you are doing any relaxation therapies. Next is preparatory command. It should be clear and concise, and you should emphasize during visual demonstration. It can be reduced when patient has learned and confident enough of his movements. Next is action command. It should be short, accurate, and timed. The words push or pull is used during isotonic, hold during isometric, relax or let go during relaxation. Next we have stretch. So it is used to increase the strength or initiate the voluntary movements and enhancing quicker response in weak muscles. Now if we are using stretch as a stimulus, then two parts of stretch reflex are included. The first one being short latency spinal reflex and the second longer latency period. Contraction following the stretch should be resisted. And if we are performing stretch, so there is contraindication for stretching when there is pain or there is soft tissue injury to the patient. Next we have traction and approximation. So traction is done to separate joint surfaces and it also stimulates movement. And approximation is for compressing joint surfaces and promoting stability. It also stimulates postural reflexes. The fifth point is maximal resistance. It is done during isotonic contraction, isometric contraction, and it is used to increase excitation, strengthening of muscles, build up endurance in the muscles, or when we want to improve coordination or the muscle demand relaxation. It should be avoided when breath holding. Next is normal timing. The definition for normal timing will be sequence of muscle contraction. Like normal timing is a sequence of muscle contraction which occurs in any motor activity that results in a coordinated movement. In normal development, it should be distal to proximal control. In normal coordinated movement, rotation is first component to be involved. Then we have reinforcement. It means it is the means of strengthening response. Reinforcement is the means of strengthening response. It includes timing for emphasis, combining patterns, and recuperative motions. Now, there are specific techniques for PNF that includes repeated contractions, rhythmic initiation, reversals of antagonists, that further includes slow reversals hold, and rhythmic stabilization. The fourth one is relaxation, that includes contract relax and hold relax. And the fifth is replication. Now, starting with the first technique, that is repeated contractions, also known as repeated stretch. So, its repetition is prerequisite for learning. In the initial stages, we perform the isotonic contractions, and in the later stages, we perform isotonic and isometric contractions for the patients. Now, this technique has two types. That is, if we are performing the repeated stretch from the beginning or through the range. And these types are for the correction of imbalances and pivots of for emphasis. Now, the goals of this repeated contractions is that it increases the active range of motion, it facilitates the initiation of motion, and it increases the strength and avoid or decreases fatigue. It also decreases the proprioception. The next technique is rhythmic stabilization, and this technique is never, and I again say never, against pain or resistance. It is totally contraindicated if there is pain in the involved part, as it involves involuntary relaxation, passive movement, and repeated isotonic contractions. Now, these are the goals of rhythmic initiation. If the patient cannot initiate the motion, then we can use this technique. और अगर पेशेंट के पास सेंस ऑफ मोशन नहीं है या फिर कोऑर्डिनेशन ही नहीं है उसके मोशंस में, देन दैट कैन बी इम्प्रूव्ड. एंड अगर पेशेंट का रेंज ऑफ मोशन इज नॉट नॉर्मलाइज्ड, either it is increasing or decreasing, then it can be improved by rhythmic initiation. It also helps the patient to teach him the motion, and also in relaxing the patient. The third technique is reversals of antagonists, and it further includes three types. The first is slow reversals. इसमें we will do first isotonic contraction of antagonist and then isotonic contraction of agonists. Why do we do slow reversals? So we do it to increase the active range of motion and increasing the strength or increasing the endurance and developing coordination and preventing or reducing fatigue. Next part is slow reversal hold, and this is done in the following manner. We'll always start with isotonic contraction and then isometric contraction. We'll first take care of the antagonist muscles. So पहले हम isotonic contraction कराएंगे antagonist की, and then we'll do isometric contraction, and then taking care of the agonist muscle, we'll again perform isotonic contraction of agonist and then isometric contraction of agonist muscles. Now, the main goal of this technique is to increase the coordination between agonist and antagonist muscles. But it also have other goals, like it also increases the muscle length and stability and balance. The third part is rhythmic stabilization, and in this पहले हम isometric contraction कराएंगे antagonist की and then isometric contraction of agonist. Rhythmic stabilization में हम सिर्फ isometric contraction कराएंगे but of both the muscles, like agonist muscle and antagonist दोनों की. पहले antagonist की isometric and then agonist की isometric कराएंगे हम. The fourth one is relaxation. It has contract relax and hold relax. Now contract relax is जब एगोनिस्ट की कोई एक्टिव रेंज नहीं होगी तो ऑब्वियसली एंटागोनिस्ट क्या करेंगी, वो रिलैक्स्ड हो जाएंगी. एंड द पर्पस ऑफ कॉन्ट्रैक्ट रिलैक्स इज दैट it increases the passive range of motion. The second one is hold relax. It includes these three types: direct treatment, indirect treatment, and whole relaxed lower reversals. And its purpose is for decreasing pain and increasing passive range of motion. The fifth one and the last one is replication. अब इतनी सारी हमने टेक्निक्स की हैं, इन सब में पेशेंट पूरी तरीके से अपना मूवमेंट करना सीख जाता है. एंड फॉर द last technique, that is replication, we teach the patient how to end the range of motion. Now coming up till here, patient fully knows the motion, how to do this, how to do that, but how to end the range of motion is facilitated in the replication part, and it's used to facilitate the motor learning. It also assists the patient's ability to sustain the concentric contraction of the agonist. And so this is all for today. Let me know if you guys want any other topic to be covered, and would love to hear from you guys. Thank you.